Welcome to Health or Consequences, the Massachusetts Healthcare and Public Health podcast that comes to us under the Commonwealth Beacon label. I'm Paul Hattis from the Lown Institute, here with my co-host, John McDonough of the T.H. Chan Harvard School of Public Health. And today we're delighted to invite with us Barbara Fain, Executive Director of the Lehman Center, a state government agency that we think maybe a lot of our podcast listeners don't know a lot about, but they will by the end of today's discussion with Barbara. Barbara is somebody I actually met about 30 years ago. She was the first state government official that I had policy discussions with, but she's done other things since she was an assistant attorney general at the time. So Barbara, if you would get started by just telling our podcast listeners a bit about your background, if you would.
So first of all, thank you, John and Paul, for having me and providing this opportunity. Just a little bit about my background. I always say I'm a lawyer by training and a public policy person, a health policy person. I've had the privilege of working in this space for most of my career. You mentioned I was at the Attorney General's office, so I've been sort of in and out of state government. I've actually worked in pretty much every sector, and was appointed 10 years ago, just coming up like in 2 weeks, as the executive director of the Betsy Lehman Center for Patient Safety, which, as you mentioned, is a state agency. It was newly established at the time, and I've just had the great fortune to be able to do a startup in state government, which has been exciting.
So Barbara, 23 years ago, in the year 2000, the National Academy of Medicine released a landmark report called "To Err is Human," which was a national look at medical errors and patient safety. The report estimated that as many as 98,000 Americans die every year because of avoidable and preventable medical errors committed in hospitals. It set off a national movement to prevent error in medicine, and then after a few years, pretty much dropped off the radar screen of the public. What has happened on this issue in the past 23 years? Are we better off, worse off? And then we'll get into Massachusetts.
So first, let's define what we mean when we talk about preventable medical error, because I don't think that's always clear to people. So these include things like medication errors, like when a patient is given the wrong drug or the wrong dose of a drug. It can include surgical errors, like when the wrong eye or leg or even the wrong patient is operated on, or when a foreign object is left in the patient. That's like the more dramatic kinds of situations. But, the most frequent causes of preventable patient injuries and death relate to things like inadequate infection control practices, also delayed and misdiagnoses, often from breakdowns in communications or other factors. So to your question of what does the landscape look like today? On the positive side, we'd say that there's been a lot of progress over the past couple of decades on understanding really what causes medical error and what can prevent it. We also have an understanding that, because it's humans in the system, we can't, the goal can't be to eliminate all human error. Part of the solution is for healthcare providers to establish strong systems and safety cultures that can prevent the errors that do happen from harming patients. And we even have amassed a pretty good body of strategies that are proven to reduce patient harm. But the problem has been that knowing what to do and actually doing it aren't the same thing. And uptake of all of these strategies, all of this knowledge has been really, really slow. So one challenge relates to change management, leading change in an organization's culture and operations is hard work. And the resources that healthcare leaders often need to support these efforts aren't widely available to all. There's also this interesting problem of low awareness and expectations, and which is why I'm glad to be on this podcast today. Other than the occasional headline, when you think about it, medical errors actually have pretty low visibility. So this leads people, whether it's the public or policymakers, to believe that these are really isolated incidents or random bad luck or kind of even the unavoidable byproducts of, a complex healthcare system that can do a lot of amazing things. Most people reasonably assume that the necessary safeguards exist and aren't aware that they're often lacking. And so all of this contributes to the fact that there's never been any real strong grassroots pressure to prioritize safety in healthcare. We have a lot of other priorities in healthcare, but safety is not top of the list. So when it comes to actual outcomes, it's hard to say if the country is better or worse or the same as 23 years ago. I think before the pandemic, there had been some good progress in certain areas. So one example is healthcare-associated infections. But unfortunately, many of those gains were eroded during the pandemic. And the good news is it does show that change is possible when you do make resources available and you have incentive structures that align. Another thing I'd mention is that the 98,000 annual deaths you referred to only include deaths associated with hospitals, but more and more care is shifting from hospitals to ambulatory settings, long-term care, including people's homes. And there's strong evidence that more serious harm events are happening in those settings. So bottom line is that despite all this work over the past couple of decades, healthcare really is still not anywhere near as safe as it could or should be.
Is anyone counting? Do we even have any sense of numbers of going up or down, improvement or decline?
It's really hard. So at the national level, the federal government does some data collection on certain areas. So infections is one area. In terms of really sort of systemic, comprehensive counting of events and types of events and trends, we don't have a good sense of that. And that is also another reason that we don't have good progress. You don't have to measure everything, but when you're not really able to measure at all, it kind of, reduces accountability.
Barbara, let me focus you to Massachusetts, which even 6 years before that landmark report to Err is Human, we sadly experienced in 1994 the death of medical reporter Betsy Lehman, which was very much in the media. She died, unfortunately. It was a global medical reporter who died at Dana-Farber at the time because of a mistaken and massive chemotherapy overdose. About 30 years later now, here we are in Massachusetts working on this problem. You're executive director of the Lehman Center, which is in charge and mission includes working on that problem. How are we doing in this state? Better, worse, or about the same as sort of John asked you at a national level?
So a couple years before the pandemic, the Betsy Lehman Center set out to answer that exact question of where are we now? And so we conducted two major studies to develop just a snapshot of the impact of medical error on the state's healthcare system in a single year. The first study analyzed health insurance claims data to measure the number of preventable harm events in a single year in Massachusetts, as well as the financial costs to the system of those events. The numbers were pretty striking. So we were able to identify almost 62,000 individual cases of preventable harm. So these are harm. These aren't like errors that didn't hurt. What we're looking at in claims data is the additional medical care that was provided to people in the aftermath of the events.
That's an annualized number you're estimating?
That was in one single year. We basically took a 12-month period and using the all-payer claims database, using a methodology that had been developed nationally, we very conservatively identified 62,000 cases, I think 400 different categories of medical errors. These events, just in terms of financial impact, they resulted in over $617 million in excess health insurance claims for that year. In that year, it was just over 1% of total healthcare spending. And a couple key points about these data. The harm events, we were able to look beyond hospitals. So anywhere that health insurance claims, anyone filing claims on any settings that filing claims on health insurance. with health insurers. So the harm events we're finding, they occur across the entire continuum of care, not just hospitals, and really everywhere. So, this means that we really can't think about unsafe care as a problem that can be solved by weeding out bad apples. It's a system-wide problem. Also, our numbers, as I mentioned, they dramatically undercount the number of events that we were using a conservative methodology. And some of the most common types of harm events, like injuries from falls or delays in critical diagnosis, we can't pick those up using claims data. So this is just a very, very conservative estimate. The second study, people like to focus on the dollars and the big numbers. We also looked at the human cost of these harm events, and through a very large statewide phone survey and follow-up interviews with Massachusetts residents, we found that at least 1 in 5 Massachusetts residents had experienced a medical error in their own care or the care of a household member in the previous 5 years. And we also got into the impacts of these events on patients and families. They're tremendous. I mean, people reporting just incredibly long-lasting physical, emotional, financial tolls. And one of the most troubling aspects of what we heard from patients and families was that basically these events cause them to lose trust in the healthcare system, particularly when providers fail to communicate openly about the mistakes that were made that had harmed them. And that was usually the case. And the loss of trust had led many of them to avoid healthcare altogether, which brings with it its own set of problems. I get back to your question about how do we compare to other states, and sadly the answer is we really don't have a good way to know. I'd like to say we're doing better than most, given how many leading experts and advocates for healthcare safety are based right here in Massachusetts. But I wish there were evidence to support that. So just to give you an example, I mean, by law in Massachusetts, the Department of Public Health mandates reporting of certain categories, 29 categories of adverse safety events, mainly by hospitals, though also surgery centers and nursing homes. But by design, those systems just pick up a small subset of all safety events. And we also know that even the events they're designed to pick up they're underreported, often because the provider organizations aren't aware that these events are happening in the first place. They don't know what's going on under their own feet. So our current data collection systems don't tell the full story. In terms of other states, we're probably more robust in our data collection than most. Fully half of states in this country don't mandate reporting of safety events at all. And as I mentioned before, there is some federal data collection, but we wouldn't want to draw any overall conclusions about how we compare nationally. We just don't know.
A lot of focus these days on inequities in our country and in our healthcare system. Any data you have on racial or ethnic minorities in our state in particular? Are they more or less likely to be on the receiving end of medical errors as compared to the population overall?
So disparities in patient safety outcomes based on race and ethnicity, also age, disability, sex, gender, and more, are actually pretty well documented here and nationally. And regarding race, whenever data are available, we almost always find disparities, actually pretty stark disparities in outcomes. Just to give you an example, the Betsy Lehman Center regularly prepares reports for the state's 40 birthing hospitals on their rates of severe maternal morbidity. And our analyses show that non-Hispanic Black patients have severe maternal morbidity rates that are about twice as high as non-Hispanic white patients. And these numbers have been pretty consistent over the past 5 years when we've been able to measure. So that's just one example. But as I said, whenever you look, you find. We don't always have the data to look, but when we do, we find those disparities in outcomes by race.
So Barbara, you run the Betsy Lehman Center, the only state agency that's named after a person, as far as Paul or I understand. How did the center come to be? What's its role? Where's your money come from? Do you have to raise it, or does it come from the state treasury? And how can you say Massachusetts is a better place because of the center's work?
So we are indeed proud to be one of only a few states, three, I think, at this point, with a state agency that's solely dedicated to healthcare safety improvement. So we're not a regulatory agency. We play a different role. The origin story is obviously very closely connected to Betsy Lehman's death. And the efforts initially of her family and some visionary leaders like Nancy Ridley at the Department of Public Health, who realized that not only did there need to be better regulatory oversight of patient safety, but there also had to be space for candid conversations where healthcare providers could come together with others to really work on the systems failures that lead to these kinds of serious harm events. At the time, there was this feeling that the only conversations that happened about safety was really in the malpractice context, and with DPH, everyone coming to the table lawyered up and not sharing any information, and that wasn't going to get anyone anywhere. So the center's core mandate is to play kind of a convening and coordinating role. We also have a robust research program and programs to disseminate information about healthcare safety, and we increasingly are providing technical assistance to provider organizations on things like peer support and communication and resolution programs and patient and family advisory councils. As I mentioned, we're not regulatory, and so we're able to maintain the confidentiality of the information we receive. You asked about funding. We're funded out of an assessment on the industry, so the hospitals, mainly the hospitals and the health plans, and just I think 1% by the ambulatory surgery centers. It's the same funding stream that funds the Center for Health Information Analysis and the Health Policy Commission. And we are affiliated with CHIA. We get our operations support there because we're actually pretty small. I think we're 12 or 14 FTEs at this point, which is a lot compared to what it was 10 years ago, but very small in terms of state agencies. Just back to our convening role, we understood from the beginning that meaningful progress on patient safety wasn't going to happen just by the Betsy Lehman Center or any single entity, and we really needed more of a sustained cross-sector effort. We also understood that safety wasn't high on anyone's agenda, and so that cost of medical error research I mentioned was aimed at raising awareness that safety is still a serious challenge, and to get the key stakeholders to the table to work on long-term strategies to overcome all these barriers that have been holding back progress. And so the Massachusetts Healthcare Safety and Quality Consortium that we lead is a very unique undertaking that came together about 6 months before the start of the pandemic, but been going strong ever since. And so through the consortium, and I've lost count of how many task forces and advisory groups we have related to it, and Paul is part of that process. I mean, literally hundreds of healthcare leaders, policymakers, consumers have been collaborated on this, a roadmap to healthcare safety for Massachusetts that we released this past spring, and they're continuing to support implementation of the roadmap. And so the Betsy Lehman Center is, we're just gratified to be able to play an important role as a convener.
I see, Barbara, on your website, it says between 20 to 25% of adults in Massachusetts have an experience with medical error in their care or the care of someone close to them. That's a lot of people. Yeah. Should people be more upset and angry and taking to the streets about this? Or is that, you don't think that's warranted? 20 to 25% of Massachusetts adults is a lot of people.
It is. And that's why, in some ways it's surprising that there isn't greater awareness. We did some research a number of years ago with the Frameworks Institute around just kind of public perceptions of safety. And we also did a similar study. So how does the public see patient safety? How do frontline providers, how physicians see it? And how does the media report on this? And it was so interesting because the general public and physicians are actually very closely aligned in their thinking, which is that people actually, trust and respect their doctors, and as they should, and you want that good relationship. They also think that the way you they don't see themselves as being personally at risk. They realize that these kinds of things can happen, but they think they happen to other people. And the way you keep yourself safe is by kind of having a caring physician. And they actually have a big distrust of all the things the patient safety experts recommend, all of these systemic improvements. They don't trust systems, processes. They sort of actually buy into the whole idea of like, well, my doctor is, heroically going to, fix my problem. If there's systems in place, if there's standardization, then they're not going to be able to do that. And that's, really the hallmark of American, healthcare is this innovation and all of that, and a lack of and no standardization. So that's why people aren't taking to the streets when bad things happen. They tend to attribute it to just random bad luck. It is interesting, though, that when you start talking to people who say, like, it can't really be that bad, when they think about it, they think, oh, yeah, well, there's, this error happened in my friend's care or in my parents' care or in my kids. When they think about it, like, everyone does have a story, but for some reason, it's not visible in the way that, like in that National Academy's report, I believe there's a comparison to aviation and airlines are an industry that complex, high risk, that have really addressed their safety issues. When planes crash, people stop, people pay attention, they address the issue. Those are high visibility events. They happen in public. When bad things happen to individual patients, they tend to happen behind closed doors. And so there is this low visibility, low awareness problem it's problematic. It's problematic. We also just want to say just one other thing. We don't want people to lose trust in the healthcare system because, yes, these things are happening, but the chances of a bad thing happening to you individually are low. The chances that there are medical errors happening today in Massachusetts is high. It's a certainty. But we don't want, the answer isn't for people to be scared and stay away from healthcare.
Barbara, you mentioned the roadmap to healthcare safety for Massachusetts, which the center published. Can you say a few things about what's in it generally? But I'm also aware that there's an important to it as a proposed pilot project that the center is thinking about. You want to let our audience know about all that, if you would.
So this roadmap to healthcare safety, it was really intended to build off the learnings from all of the pioneering work that's been done over the past couple of decades. There are it sets 5 long-term goals for the state. They relate to leadership, improving leadership and culture, operations and engagement, provider organizations, patient family support, workforce well-being, and measurement and transparency. Kind of the theory of change behind the roadmap is grounded in a 3-dimensional approach. First, we need to inform. People need to be informed, and that's when we say people, we mean patients, we mean providers, we mean policymakers, everyone. Everyone plays a role in safety. The second piece is we need to provide implementation support to provider organizations. We know from the failures of the past couple of decades that information alone, just saying here's how some other organization fixed this issue, that's not enough to build a safety culture or safety operations. We actually need to develop learning resources and tools to help providers implement continuous improvement systems that really enable them to routinely identify safety risks and act to eliminate those risks. And third, we need to incentivize. Because just having information and implementation supports available, it's a start, but we can't assume that providers are going to be intrinsically motivated to use them. And so there have to be some accountability structures that motivate leaders to prioritize and to act on safety and to reward them when they do. Always starting with the carrots, but not, but moving to the sticks if we need to. Do you want me to? I can jump ahead to the.
Why don't you tell us about the pilot that I referenced, and then John is probably going to turn to our last question area.
Okay. So the pilot it gets back to this original challenge of needing better data. Most healthcare providers operate under a good faith belief that that their individual performance on safety is strong, or in any case they're doing as well as they can. And so if we're going to reduce preventable patient harm, providers need to know how they're actually doing on safety so that they can improve. And for that to happen, they need more timely, actionable information than they have now. So the pilot you referenced, it's a pilot to leverage new technology that can run in the background of any hospital electronic health record to automatically detect a wide range of patient harm events in real time. So this is pretty groundbreaking. The data that the systems pick up are then analyzed by clinicians to weed out any false positives. They're entered into interactive dashboards that are available to hospital leaders and frontline staff. And finally, hospitals receive expert advising and coaching on how to take the data, how to apply that data, and fix the underlying risks that are causing the harm events. This last piece of it is really critical. What's most exciting about this approach are the dramatic reductions, unprecedented reductions in patient harm events that early adopter hospitals elsewhere in the country have achieved. So that's where we're looking to break new ground. This would be a first in the nation pilot to introduce these systems in a diverse cohort of up to 8 Massachusetts acute care hospitals, kind of a feasibility study. These systems are not yet being used by any Massachusetts hospital, but our goal is to determine whether and how an approach like this eventually could be scaled statewide, even beyond hospitals, to reduce preventable harm and and the costs that come with that. We already know that these systems do a superb job at flagging safety events from patients' clinical records. But it's also important, and what we're trying to figure out is whether these systems really help with improving organizational safety culture, operations, workforce well-being, and if they could provide the state with a better source of information than we now have about patient safety risks and trends. So back to John's question about what are we measuring? Well, whatever we're measuring, we're not getting that much useful information. Could sort of drawing from the clinical record for the first time, would that make a difference? And then also, eventually the data being produced could support greater public transparency. We know that transparency is absolutely critical to holding providers accountable for safety, but most of the data we have, it doesn't meet the informational needs of the public. And so I wouldn't rely on the data that we currently have to make decisions about my own care. So it doesn't seem right to put that out there. So we need a better source of data if we're going to have public transparency. So the pilot is just now getting off the ground. We've convened an expert task force to guide the project. We've begun a procurement process to secure a leading vendor. And we're going to use the first half of 2024 to recruit and select hospitals with the goal of actually implementing a data collection and analysis next summer. We have the funding we need to carry us to that point, but we need additional funding, hopefully through the fiscal year 2025 budget to start the data collection piece of it.
When physicians talk about medical errors and patient injury and so forth, it quickly gets into, they complain about how high their malpractice liability premiums are. When patients get involved, they usually complain that they had an injury and the institution would tell them nothing. And there was an initiative in Massachusetts that started a number of years ago on communication apology and resolution. I think it's called the Mass Alliance for Communication and Resolution following medical injury. What has happened to that whole movement? There was a lot of interest and hope that it was going to lead to some breakthroughs. Do you know what the standing of that is right now?
Yeah, so funny you should ask. So that was the Macrame program, and as of less than a year ago, it has come under the wing of the Betsy Lehman Center. So we've actually absorbed that program, and with the goal of really scaling it statewide. I want to be able to say how many hospitals are participating at this point, but it is a growing number of hospitals. It's had some, really good successes. One of the challenges with that, what we're finding is when you think about when serious harm events happen now, they're the result of a series of mistakes. I mean, people are moving through the system. There's a lot of, something might happen in a physician's office or in your long-term care facility, and then you end up in a hospital, and then you end up somewhere else. And so how do we make these programs available to patients and providers when the harm event really is the result of a series of mistakes that have happened in different settings, not with the same liability carrier, not in the same healthcare system even. So, but we do think that these programs show great promise, and that's why we're making the investment.
Barbara Fain, thank you for joining John and I today, telling our audience a fair amount about the Lehman Center, and thank you very much for your time.
Thank you for having me.